Hypoxic pulmonary vasoconstriction is a physiological phenomenon in which pulmonary arteries constrict in the presence of hypoxia without hypercapnia, redirecting blood flow to alveoli with a higher oxygen content. The process might at first seem illogical, as low oxygen levels should theoretically lead to increased blood flow to the lungs to receive increased gaseous exchange. However, it is explained by the fact that constriction leads to redistribution of blood flow to better ventilated areas of the lung, which increases the total area involved in gaseous exchange. This improves ventilation, perfusion ratio and arterial oxygenation, but is less helpful in the case of long-term whole-body hypoxia. This is seen in COPD, at altitude, and in heart failure. Several factors inhibit this process, including increased cardiac output, hypercapnia, hypothermia, acidosis, alkalosis, increased pulmonary vascular resistance, inhaled anesthetics, calcium channel blockers, positive end expiratory pressure, high-frequency ventilation, isoproterenol, nitrous oxide, and vasodilators. High-altitude pulmonary edema. High-altitude mountaineering can induce pulmonary hypoxia due to decreased atmospheric pressure. This hypoxia causes vasoconstriction that ultimately leads to high-altitude pulmonary edema. For this reason, some climbers carry supplemental oxygen to prevent hypoxia, edema, and HAPE. The standard drug treatment of dexamethasone does not alter the hypoxia or the consequent vasoconstriction, but stimulates fluid reabsorption in the lungs to reverse the edema. Euler-Liljestrand mechanism. This describes the connection between ventilation and blood circulation of the lung. If the ventilation in a part of the lung decreases, it leads to local hypoxia. The local hypoxia leads to pulmonary vasoconstriction. This adaptive mechanism is beneficial, because it diminishes the amount of blood that passes the lung without being oxygenated. The mechanism was discovered by two Swedish pharmacologists, Ulf von Euler and Göran Liljestrand, at the Department of Pharmacology of Karolinska Institute in Stockholm. The molecular mechanism seems to be mediated by oxygen-sensitive potassium ion channels in the cell membrane of pulmonary smooth muscle. With a low partial pressure of oxygen, these channels are blocked, leading to the depolarization of the cell membrane. Calcium channels are activated and cause the influx of California 2+ ions over the membrane and to the release of calcium from the endoplasmic reticulum. The rise of calcium concentration causes contraction of the blood vessels, smooth muscle fibers, and the resulting vasoconstriction. Histamine has also been implicated in this mechanism.